And our next speaker, and our final speaker, is an endocrinologist that I know we were all excited about that earlier. We're lucky to have Dr. Sidhaye from Johns Hopkins, and he sees patients with Dr. Fatimi, so he's knowledgeable and can help us share some light on that topic.
So thank you to the organizers for inviting me and for Dr. Fatimi for allowing me to be involved. So the way I got involved with this was I'm a clinical endocrinologist, and essentially Dr. Fatimi's group said, would you like to see some of our patients? And so we've established a system where on the day of the clinic at Kennedy Krieger, we have a simultaneous clinic where we try and see. So I've learned a lot over the last couple of years, and we'll try and share some of what I've learned, as well as providing just some basic information to you. So just a little bit of history, perhaps not necessary for this crowd, but ALD was described originally in young boys in the late 19th century, and in adults, reports of hereditary spastic paraplegia associated with adrenal failure emerged in the late 1950s. And in the 1970s, there were autopsy specimens that described these lipid inclusions based on electron microscopy studies of the adrenal glands. It turns out that these lipid inclusions contain cholesterol, phospholipids, gangliosides that were esterified with very long-chain fatty acids, which, and this all happened, I guess, about the time that I was probably born, but that eventually led to the development of the assay, the very long-chain fatty acid assay. What are the adrenal glands? The adrenal glands are paired glands that sit right on top of the kidneys, and they're really two glands in one, as it turns out. And this just shows you a section of the adrenal glands. They're very, very, very small, normally speaking, and they have a capsule, a cortex, and a medulla. And when you sort of slice it open, what you can see is that the cortex actually has 3 different zones. And each of those zones is actually specialized to make different hormones. And it turns out that the lipid inclusions that I talked about before are mostly in what's called the fasciculata, and the reticularis. So they're not actually present necessarily in all zones. And it's thought that these inclusions trigger reaction and eventually sort of a progressive decline in the function of those zones. And so I think, so in the adrenal cortex, the 3 zones in the adrenal cortex make aldosterone. Aldosterone is a hormone that essentially helps the body retain salt, and it is the major hormone that allows one to do this. This zone, theoretically, is not or less affected in patients with ALD. The next 2 zones make cortisol and androgens, or really weak androgens is really what it is. So the weaker form of male hormones, male sex hormones. The cortisol is, of course, the most important for us here. Cortisol has several functions, normally speaking. We consider it to be a stress hormone. And so, for example, one of its most important jobs is to allow other hormones that might be increased during stress to work, specifically those that allow your blood pressure to be maintained. So if in a stressful situation, let's say in the setting of a bad pneumonia, other hormones are necessary to help support the blood pressure, you actually need cortisol for that to work. In addition, cortisol has major effects on the metabolism of carbohydrates and fats, essentially driving nutrients in a way to support blood glucose. So it's very important to respond to a stressful situation, usually major infections or loss of blood, something like this. The adrenal medulla makes catecholamines or adrenaline, for example, and it's thought not to be effective. So just a little bit about natural history. Adrenal insufficiency is thought to affect, depending on which reports you read, and the studies are of course affected by the ages of the patients that they're investigating. Anywhere between 50 to 100% of males can be affected. Females are less affected, but what I've learned over the last couple of years is that there is a finite number of females, about 1%, that do develop adrenal insufficiency, meaning inability to produce cortisol in adequate amounts. What this is meant to show is that over the course of time, so between age 0 and above, this is when you can develop the different characteristics of ALD, be it adrenal insufficiency, myelopathy, or cerebral ALD. There are many modifying factors that affect who gets what part of the disease. Not all of them are well characterized, but the most important thing from my perspective is the idea that adrenal insufficiency can occur at a very early age. And so especially now, I know that some states have newborn screening, and so patients can be identified very early. It's important to know whether they can develop adrenal insufficiency that early. And the answer is yes. And from what I can tell, the earliest age that this has been diagnosed in someone who does not actually have symptoms of adrenal insufficiency, that is, that you can detect biochemically that there's cortisol deficiency, but maybe the person doesn't have any symptoms, is age 5 months. So that's very early indeed, and so it constitutes the rationale for a recommendation that screening be done starting at an early age and yearly, at the very least, if not more often. So here are some of the signs and symptoms of adrenal insufficiency. Patients can have fatigue. Oftentimes, sort of the classical description of this is that, especially in the afternoon, people just feel like they have to take a nap, is how a lot of people describe this. There can be lightheadedness, either just all the time, or especially when people stand up, what we call orthostasis. People can have nausea, anorexia, and even vomiting if the situation is significant enough. There's this vague abdominal discomfort that people have that is hard to characterize, but there are some unusual abdominal symptoms. People tend to lose weight, and although I'm not a pediatrician, in the pediatric population, this might more manifest itself as an inappropriate weight gain or inability to gain weight rather than weight loss per se. There's often a very unusual tanning of the skin that can occur. Signs include loss of pubic or axillary hair. Patients can have low sodium or high potassium levels depending on the degree of involvement in their blood levels of potassium and sodium. And in what we call an adrenal crisis, this is a situation usually where there's another illness going on, perhaps an infection, perhaps blood loss, perhaps a heart attack, for example, where because there's not enough cortisol, the body can't respond properly. And usually we see very low blood pressure, low blood glucose levels, and even confusion. So these are just sort of the very basic symptoms that we, basically ask about at every visit. So to diagnose this, and essentially, we're fortunate in a way that we have blood tests that can help diagnose this relatively easy. And we recommend starting with just screening tests where you measure cortisol itself, and we're looking for if the level is low. And we measure ACTH. This is the hormone that is secreted by the pituitary gland that signals the adrenal gland to make cortisol. And if the levels are very, very low, normally the ACTH levels are very, very high. It's a simple feedback system, say similar to the way your thermostat might work at home. And although the cutoff is a little controversial. Most people think that if you have a morning cortisol level that is between 3 and 5 milligram per deciliter, and an ACTH that is twice the upper limit of normal, that in ALD patients, at least, this essentially confirms a diagnosis of adrenal insufficiency, and I often will not do any further testing, because if there's this along with some symptoms, then this is enough for me. And I wrote confirmatory testing. I really, as I was driving down here, I thought about this word. This word is not correct in my opinion. It should be diagnostic testing, the accepted diagnostic test. So if any patient does not meet the above criteria, I suggest that they get this stimulated testing. And in that case, what we're trying to investigate is, well, if we give a big slug of essentially ACTH, the thing that normally stimulates the adrenal glands, will they make cortisol? And it's a pretty simple test to do. Essentially, you administer cosentropin, which is ACTH, and draw blood to check cortisol at baseline, at 30 minutes and 60 minutes, and there are accepted cutoffs for what constitutes adrenal insufficiency and what does not. And so this is really the accepted diagnostic test. Again, I'm not a pediatrician, but I'm pretty sure that in the first year of life, you cannot use the first test. So they have, if you're going to do testing, you have to do the second test. The stimulated testing has to be done. Now, this is to detect deficiency of cortisol. Remember, I told you there were 3 hormones that were made. Typically, aldosterone deficiency is less common, but there are labs that we can do to investigate that as well. And so we usually order a metabolic panel to look at the sodium and potassium levels, as well as an aldosterone and something called a plasma renin activity, and use all these numbers in conjunction to determine if there's also aldosterone deficiency. And the reason for that is that there are specific hormone replacement treatments, if that is the case. Okay, so how does one manage this? Endocrinologists are relatively simple people. If there's a deficiency of a hormone, we simply provide replacement. And in the case of adrenal insufficiency, we give glucocorticoids, so that is essentially cortisol. Hydrocortisone is what's available, and that's actually what your body normally makes. And in adults, the dose usually is somewhere between 15 to 20 or 25 milligrams per day. And it's a balancing act, because if you give people too much, there are adverse consequences of giving people too much hydrocortisone. Probably the most significant are weight gain, specifically a redistribution of fat, and excess cortisol is toxic to bones and causes thinning of bone, otherwise known as osteoporosis, which would be a risk factor for developing fractures. So over many years, if somebody's overtreated, that's a major problem. And so we try and aim for about 15 to 20, depending on how people are doing. And hydrocortisone is very short-acting. So its duration of action is just simply on the order of several hours. So usually you have to dose this 2 to 3 times a day. We usually suggest that hydrocortisone be taken first thing in the morning, as soon as you wake up. And the idea is that that's actually normally what happens. The cortisol levels surge in the morning and are almost undetectable by bedtime. And so we're trying to provide a surge in the morning, although, as you could probably tell, we're going to be a little late because we're waiting for the patient to wake up to take the pill. And then they usually need another pill at about 2, 3, 4 o'clock in the afternoon. Some patients even need the dose to be divided 3 times a day. There are other glucocorticoids, prednisone, prednisolone, dexamethasone. There's nothing really to say that one is better than the other, and if for some reason a patient is not tolerating, or maybe the hydrocortisone is just not working for them, or they just can never get around to taking that second dose in the afternoon, I think there's no harm in trying the other formulations, and sometimes it works better for people. The mineralocorticoid is called fludrocortisone, and it's usually dosed between 0.05 and 0.1 milligram per day. And this is the hormone that allows you to retain salt. Now, in patients who have adrenal insufficiency, who also have deficiency of aldosterone, or the mineral, which is a mineralocorticoid, we often find that if you don't give this to them, you need to use a higher dose of hydrocortisone. And so it's a way of making sure that you balance the doses correctly. So it is important to identify if this is present or not. Okay, so that's at maintenance. Of course, I told you that adrenal insufficiency, or I'm sorry, cortisol is a stress hormone. So what are patients supposed to do if they get sick at home? And so this is probably one of the most important things we try and tell people. So if somebody does get sick, they should take whatever glucocorticoid they're taking, and we generally advise that they take 2 to 4 times their typical daily dose. So if they take 15 or 20 milligrams of hydrocortisone, they should be taking about 60 milligrams of hydrocortisone over the course of the day, usually equally divided. In general, we don't think there's any reason to increase the mineralocorticoid or aldosterone equivalent. So what constitutes a stress? So a fever greater than 100.4, nausea, vomiting, head trauma, fractures, or any dental work or anything that's going to require sedation. Now, in general, psychological stress or intense exercise does not usually require this sort of stress dosing, we call it, this higher doses of hydrocortisone. And I think that if, however, somebody also has a mineralocorticoid deficiency, that is, they need Florinef or fludrocortisone, that if there's going to be a lot of salt loss, I have a patient who's a firefighter who has another adrenal condition, I tell them to take an extra teaspoon of salt. In those circumstances, I think it is advisable if there's going to be a lot of salt loss and you also have a salt retaining problem, to take an extra teaspoon of salt. So the one thing I will say is that once the stress becomes so severe that there's actually nausea and vomiting, that is, there's no way the person can stay hydrated by themselves, things have to move quickly. This is one of the life-threatening situations in endocrinology. If there's a stressful situation and there's not enough hydrocortisone or cortisol given. So everybody is prescribed an injectable form of hydrocortisone, and it should be available and administered in case oral intake is not possible. So if you can't take those extra doses of pills, then you need to have this injectable form, and as soon as this injectable form is given, then you need to call 911. And so I was looking for videos, because it's a little bit complicated how this works, and so your loved ones or your family members or your partners, whoever need to know how to do this for patients, kind of have to have gone through it before once or twice. And so we advise that they find videos, and I recently found a video from CHOP that shows how this thing has to be administered. Because it's not so simple as pulling something out and injecting it. It has to be diluted. It's pretty straightforward, but I encourage you to look at that video if you take care of somebody who has this condition. The other thing is we advise all patients to have a medical alert bracelet, and it should say adrenal insufficiency requires hydrocortisone. This is so that if let's say you're in an accident and an EMT turns you over, they should see it and know that they need to give hydrocortisone. It is life-sustaining in that circumstance. And we always try and provide written instructions, and periodically I try and review when it is that you should give stress dosing. And this is something that causes confusion for people. And I think that when am I supposed to take these extra doses of hydrocortisone or prednisone that I have at home is something people don't understand. But the bottom line is if you have a fever and or an infection, you should take it. And when the fever and or infection is done, you don't need to take it anymore. You can just go back to what you're normally taking. But if you can't keep anything down, if you can't keep pills down, then you need to get to an emergency room. So, you probably have gathered that this adrenal insufficiency is likely to evolve, and in whom it evolves soon versus later is not 100%, we don't know. so, first off, we do suggest that a stimulation test be done periodically, even if the patient's not having any of those symptoms, feeling a little tired, maybe not having as much get up and go. So even if they don't have any symptoms, we do think that stimulation testing should be done. Sometimes patients may not stimulate appropriately, but their ACTH is actually not that high. And this probably represents a situation where their adrenals can make enough cortisol when everything is fine, but in a stressful situation, they may not. And in that circumstance, we do advise some patients to have some on hand if they get sick, if they get a bad infection, to make sure they take these extra doses of steroid. Okay, so one question is, do investigative treatments affect the development of adrenal disease? And so this has been looked at probably by some of the people in this audience. And so in the Lorenzo's oil studies, they found that if adrenal insufficiency was already established, it was not reversed. But that new onset adrenal insufficiency or progression of adrenal insufficiency in people who had adequate cortisol levels but maybe high ACTH levels, that this was actually delayed. In the case of stem cell transplant, progression and onset of adrenal insufficiency was not affected, meaning not delayed. So that's the adrenal glands. I'm going to shift to one of our other important steroid hormone-producing glands, the testes. Maybe I'll just stop for a second for questions, or I can wait. I can take questions at the end as well. But it turns out that those lipid inclusions were also identified in the Leydig cells of the testes. So the testes, one of the most important functions, of course, is to make testosterone and to make sperm. And these inclusions have been found both in patients who have AMN as well as ALD, so really in all phenotypes of the disease. And hypogonadism, that's the word we use for decreased function of the testes, is typically seen after the onset of either adrenal and neurologic symptoms. So usually we think of it as a relatively late occurrence. Its clinical significance is difficult to judge, and the reason has to do with the non-specificity of the symptoms that people have. And so here are some symptoms of people who have low testosterone. Everybody has seen advertisements for low T, and decreased libido, loss of body hair, gynecomastia, meaning breast development in males, erectile dysfunction, decreased ability to complete sexual intercourse, decreased energy, concentration, sleep, and muscle mass, and low bone density and increased fat mass. These are all findings of testosterone deficiency. In general, as endocrinologists, we only think that the top 4 are truly specific for testosterone deficiency. That is, you could probably guess that there's a lot of reasons people don't have energy or can't concentrate or don't sleep well that actually have nothing to do with testosterone at all. And so the symptoms may be very common, but low testosterone levels are actually less common. So people have studied this prospectively, and as many as 80% of patients will have symptoms that sound like hypogonadism, but then only about 50% or less will have actually low testosterone levels. Now, that's still a high percentage of people that have low testosterone levels in this patient population. And so I still think it's more common than in the general population. I think that symptoms should be queried by endocrinologists or treating physicians, and treatment offered if indicated by labs or the clinical scenario. So while there's lots of people out there that go to urologists and get testosterone because their T is quote-unquote low, I feel like this is one situation where it's warranted. Treatment is warranted. And the reason is manifold. Testosterone can help maintain muscle mass, which may be relevant as time goes forward. And the other thing is that you need testosterone to keep your bones healthy. And so again, with time, to try and help prevent bone loss, it's important to maintain sex hormone. Let's say there's, generally speaking, a lot less information about testicular dysfunction than there is about adrenal insufficiency. So in summary, AI is obviously common in patients with adrenal leukodystrophy, and its incidence actually increases with age. So having had a stimulation test done at one point in time is not enough. It could be that it develops over time. And so we advise screening for AI strongly, even in people who do not have symptoms. I think you all can understand that treatment for AI is life-sustaining, and that we as physicians should always emphasize the safety measures that I talked about, such as medical bracelets and making sure that there's injectable hydrocortisone available at home. For testicular dysfunction, the deficiency of testosterone may be common. We should try and elicit symptoms and test for it, and if we find something is deficient, I think replacement of testosterone is indicated. And I think that's all I have. Yep. And I'm happy to take your questions.
I got a billion questions.
And you need to
fire away.
So I was put on hydrocortisone about 7 years ago. I tested slightly out of range, and my endo at that time said, maybe we should start you on this. I'd already been diagnosed with ALD, and I've been on it for 7 years. I've never had any issues, but then I wonder, maybe I have had issues, I just don't know what those issues are, because one of the things I would say I really struggle with is the man juices. You know, like we're talking about testosterone and like,
Yeah.
You know, just like getting going. And I'm wondering if there's anything out there, whether it's over the counter or prescription. I'm not really interested in steroids and getting, I'm not really interested in going down that route. But I'm curious, like I take DHEA from time to time. Are there any things else out there that I could explore or try that might ramp me up a little bit?
Sure. So I think that there's a really strong rationale to test for testosterone deficiency, and if that's present, to treat it as such.
I recently had that done, and I scored within range. I was like 550 or something.
Okay. So let's take 2 steps further. So the total testosterone assay is not the best assay. So if your physician hasn't checked a free testosterone, we do that. And frankly, that assay is not the best either. But I think that you can use those numbers in conjunction with how somebody's feeling to make a rational decision about what is to be done. The other thing that I didn't talk about, in general, we think that the testosterone deficiency is related to the disease in the testes, but there may be some information that suggests the problem is not with making testosterone or in addition to that problem. It's with where testosterone acts. So that is to say, the level of the testosterone receptor is where there might be some problems. And that we kind of have no way of, actually figuring out. So I think that, there's a really good rationale. In terms of stuff that's over the counter and things like that, the one thing I always have a lot of worry about is that there are oral forms of testosterone that's available, so pills, most of it we get is by patch or by injection. The way those are formulated, they can cause liver dysfunction. And so I always worry about, you just never know what's in these supplements because they're not regulated. So I generally discourage people from doing that. With regards to DHEA, so the adrenal androgen, the main androgen it makes is something called DHEAS. So it's a very weak androgen. It might be relevant in women, perhaps, but I think in males, testosterone is many, many, many times more potent than DHEAS, and I think it probably doesn't have much of an effect.
Yeah.
I think there are ways to try and optimize the hydrocortisone dosing if possible. And then finally, having done all that, it could be that kind of the get up and go issue is not to do with this. It could be. But I usually don't say that until I've kind of tried a different steroid hormone, or tried a different formulation of hydrocortisone, a different dosing schedule.
I'm actually a nutritionist, and I used to work with the children with ALD on Lorenzo oil. And I know I have to monitor their growth, make sure that what we put them on should be. So I have two questions. So, is there a different form of supplement? The hormone supplement stunted the growth?
With respect to hydrocortisone, with to steroids?
Yeah.
The biggest problem for growth is when we overdose patients. So higher doses of cortisol or its equivalents will stunt growth. And I would say that it is challenging. Like, I'm not a pediatrician, so I don't know how they dose it exactly, but I know it's a big struggle to find the right, to sort of dose it appropriately. I don't know if there are any pediatricians in the audience that could comment, but I think that in general, as kids grow, there are weight-based parameters that can help with that.
Is there a difference between Florinef and other brands?
So in terms of, for Florinef, which is the aldosterone, there's really no other brand that we use. In terms of the other steroids, so hydrocortisone, prednisone, and dexamethasone, what I would say is that the hydrocortisone allows you to fine-tune the dose the most because it's short-acting, it has to be given multiple times during the day. Dexamethasone is 40 times as potent as hydrocortisone. The dose is much lower, but there's less fine-tuning that can be done with that as well. And I think a pediatrician has to judge, well, do I want to make sure the kid gets the steroid? And so sometimes you pick something that's dosed once daily for the sake of safety and for the sake of practicality. But I think probably my guess is that the safest, or in terms of fine-tuning the dose, hydrocortisone allows you the most flexibility in doing that.
My second question. So you did say about the high mineral cortisol actually is in relation to sodium level.
Yeah.
Sometimes in our children group, the parent would put on really healthy diet, because I was supposed to say about that. But then also interpret to be low salt diet as well. So I believe that they shouldn't be restricted so by any means. Is that correct?
I think people who have deficiency of aldosterone or mineralocorticoids, you almost won't be able to restrict their salt. They actually have salt craving, and there's no rationale to do that.
Do you test adrenal function in women, AMN patients? If we test normal, do we need to be retested, and how often?
That's a good question. I think many people say that you do not need to be retested. But for me, because the disease is progressive, I think it's rational to at least screen with just a simple blood test with cortisol and ACTH. But probably stimulatory testing is not required and not indicated. It's rare enough, 1% of people that are affected, that it's not necessary. But I do, maybe not the yearly test that we do suggest with Dr. Fatemi's group, but periodically we do think it's reasonable.
How soon to be tested again?
Yeah, there's no guidelines about that. I think every 2 or 3 years would be reasonable if somebody's not having symptoms. Of course, if somebody's having symptoms, then it's a different story.
So, do you know of any link between long-term steroid use and cardiovascular disease? We've recently been told yes. Travis was just diagnosed with ALD and diagnosed with cardiovascular disease, and the doctors seem to suggest a link.
Between treatment for adrenal insufficiency?
Yes.
Okay.
Or, no, I'm sorry, long-term steroid use. He's been on hydrocortisone and dexamethasone since he was 12.
Since you were, okay. I think that I'm not aware of any definitive links. What I could say is that if you've been treated for a long time, because of the effects on carbohydrate and lipid metabolism, if the doses were excessive, it's possible that you could have, say, metabolic syndrome, for example, and that's a cluster of phenomena that is associated with cardiovascular disease, but it's not a rationale, you know, like, you need hydrocortisone, and that's not something that I factor into my mind. I would say that the bigger reason to not overtreat somebody is, I have a bigger concern about their bones. Now, that could be that's because I'm an endocrinologist. I mean, I think that's, for me, is the bigger concern. If somebody has a fracture, that's going to affect their life as well. And so there is a rationale to not give people too much, but I don't think cardiovascular disease is a big concern. Yes?
At what age would you start testing a young ALD patient testosterone?
For testosterone?
Yes.
I would say if there are no concerns about puberty, if the child is going through puberty, there's nothing to worry about. And in that regard, they would be similar to anybody else that's not going through puberty. So I don't think the testosterone deficiency occurs early enough in most clinical based on most clinical observations, that it's much of a concern. But if puberty is not happening, then you would test anyway.
Okay, thank you.
Hi. My son was on hydrocortisone since he was 3.5 years old, went through transplant, had some complications, massive amounts of steroid and chemo. White race was a common thing that we had to deal with.
Right.
From the age of 8, he has severe osteoporosis of the bone. He is 13 years old. In the last 2 years, he broke his rib, either one, 4 times. So that's a big concern to us. But I try when he gets sick and to double dose him, and you know, my endocrinologist triple dose him. No, I try and hold off depending on how severe it is, because, you know, he's going through so much. But that's his situation, because at the transplant, having a lot of issues, that he got massive amounts, so I'm saying not to be too concerned. You know, over time, it was just the way it happened. The one other thing I want to bring up here is another FYI, sorry to be so much FYI for you today. With regard to children in school and even adults, protocols for if you call, your child is having a crisis, or an adult, and you call an ambulance, that there are different criteria in different states, different counties, different everything. And we had a horrible incident where the first time my child had a crisis in school, paramedics were called, and of course we were called too. We were called first, paramedics. We both got there at the same time. The nurse is drawing out the solid cortex, and the paramedic stepped in and said, hold off, you can't give that. And I was like, wait a minute, my child needs stressful steroids, he's having a crisis. He was talking to us, speaking to us, but he was saying he couldn't see anything, so we knew, you know, and he had thrown up as well. To make a long story short, they refused to give him the hydrocortisone. He started to go down, we could see him, and then he blacked out. Blood pressure was dropping. They had to bag him in the ambulance. I'm on the phone with my endocrinologist, and she's saying, where are you now? And they said, 2 minutes from the hospital. She said, when you get in the door, say that this child needs steroid ASAP. He's now seizing at an awful rate. So they got him on the table, and I have about 12 doctors, you know, in there. The whole room is crowded. It's, you know, ALD is another thing they have to deal with. Because they had to stabilize him, and they intubated him because his breathing was so low. And then they gave him the steroid. But guess what? He came through right away. But because he was intubated, then they had to give him a paralytic. And he was transported to a children's hospital, and they said, my God, what did they do to this child? And I explained to them. So I've since found out, I'm on AU United, that this is a common thing, that your ambulance corps is regulated by the hospitals from whatever their protocol is. That's how they go. And they consider solid cortex a whole med. I was concerned. I said, look, if somebody was having anaphylactic shock, you know, would you question it? If somebody was a diabetic and they needed, and he said, no, we have that here. We don't have solid cortex, so it's considered a home med, so we're not allowed to give it. So I almost lost my child going through that. I put him through transplant, and I couldn't believe that because he had a crisis, and nobody had informed me. I just, you know, that this should be something somewhere. We never heard it from our endocrinologist. Nobody knew about that. He said, oh, you know, this is not something we
Thank you for sharing that. I'm not sure that's widely understood in the medical community.
Pardon?
I'm not sure that what the situation you're describing is widely recognized.
Right. And he, by the way, he did have a medical alert bracelet. They, to be quite honest, they looked at it and didn't pay too much attention to it, which I was shocked at too. So I said, thank goodness. I mean, I'm an advocate for him, but what if it's an adult going through a crisis and the same situation, they can't speak for themselves? Just something to everybody to watch out for.
Give solid cortex, then call 911.
Yeah.
I was just going to say, my son's protocol at his school is call us, inject, call 911, but no one would ever wait to give it until the ambulance showed up. They have a different job. Their job is not to push emergency corticosteroids. Their job is to safely transport and get and administer whatever protocols that they're familiar with. But you can write that into your school protocol. It's in there now, yeah.
He said, I put my foot in the door. You're not allowed to take it. I mean, we were the same distance, and it was our first experience. We never had to even give you a shot before that. So it was just something for new parents.
Right, to make sure you know, because they'll follow your lead because you're the expert, so your school will follow.
Yeah, that's very good advice for new parents.
So my experience too is that ambulances don't even carry the drug, so best to inject first, or call 911, inject, and then wait. Even if they know to do it, and we had that one emergency with our son where they did know what to do, but others where they didn't. So we inject, you know, we have someone inject. Could you take a moment to explain circadian cycle?
Sure. The adrenal gland makes cortisol, and it's not made at a constant rate throughout the day. The rate of cortisol production surges substantially between about 4 and 8 a.m., and then essentially the levels of cortisol steadily decline over the course of the day, such that by bedtime, most people's cortisol levels are very low, close to undetectable. And so there's this, you know, rise in the morning and then a fall of cortisol through the day. And the reason we typically suggest hydrocortisone to be given first thing in the morning is to try and get that dose, because its onset of action is actually relatively rapid, is to try and get some cortisol in early in the morning. But obviously you can see that we cannot mimic the appropriate, the normal circadian rhythm of cortisol. And so that's just the way the pharmacology of the currently available medicines is. We typically don't tell people to take their medicines at bedtime or in the evening because we don't want a surge of glucocorticoids at night because it's part of how people sleep. So it is a limitation that we have currently. I would say that 80% of patients, roughly speaking, who have adrenal insufficiency of whatever ilk are relatively satisfied with the currently available medicines, but 10 or 20% are not.
I just want to make a quick comment because we talked a little bit about school and maybe for some of the newer parents. I may get the numbers wrong, but I know at least our boys in the school, it's like a 504 program or whatever is that the right number? My wife takes the lead on that, so. But in any case, that's available. You know, we have meetings each year with the teacher, with the principal, with the nurse, and it's its own deal, and I'm not sure if everybody knows that it exists. Maybe it's common knowledge, but it may not be for the parents here with children that are not of school age, that you can get that special meeting, and where nobody can drink water. My kid's got a bottle on the table, and there's some special things that you're allowed to get away with that might help you in the school age years.
My turn.
Yeah.
For parents, yes. For parents that found out through newborn screening, when do we start testing our babies for that? And it sounded like there was some reference to below a certain age.
So from what I could tell, was it New York State that was the first state to do newborn screening?
Mm-hmm.
Based on their guidelines and recommendations, and since the earliest diagnosis biochemically of adrenal insufficiency is at the age of 5 months, that screening is recommended to start within the first year of life. So really within the age of 6 to 12 months.
But you talked about stimulation testing for that young.
Yeah.
How would you do that with a baby?
I'm not sure. I don't order those. Does someone know? Okay.
Brody had a lot of stim tests because in the beginning they started testing him pretty early because they didn't know in Connecticut. So I think his first blood test was maybe at like 3 or 4 months, and his was kind of borderline. So they started stim testing him at about 6 months. And what we did is the endocrinologist would order, we went to an infusion center attached to the hospital. They put an IV in him. They dropped the baseline off of the IV, so he usually only got 1 stick because he had pretty good vein in the right side. And then they would infuse the medication, and then they draw it 30 minutes and then an hour. Is how they did it for him. And then we were doing that quite often because his numbers weren't good. And then we stopped the stim because they weren't good, and they were just monitoring his ACTH and cortisol.
That's very similar to how it's done in adults, actually. You go to an infusion center, they place an IV, and all the tests are done off of that.
We actually, I'm sorry. We have been tested by an endocrinologist, but his numbers were normal.
Okay.
So I didn't know if we should still get it stim tested or if that's enough.
I think that after the first year, after that, the circadian rhythm is established, and you could reasonably just get morning blood tests as a first step. But in general, if they are unless they're diagnostic of adrenal insufficiency, when the levels are really low and the ACTH levels are really high, in the middle, you just don't know. So in that circumstance, I think that it's wise to at least once a year get stimulated testing.
So I know this is a very important topic in the community, but we are an hour behind. So I'm going to, thank you so much for being here.
So thanks, Kaylee. To those of you I haven't forced myself upon and introduced myself and made small chat today, I'm Catherine O'Sullivan-Fortin. I'm an ALD mom. I'm a carrier. I'm on the board of directors for ALD Connect. I just wanted to take a moment to thank each and every one of you, and for everyone who's watching on the internet. Thank you for taking time to plug in and really come and join our process of bringing all stakeholders together and for finding answers. And it never ceases to amaze me how much expertise comes from people. It's not just the doctors and clinicians, but so much expertise comes from patients and other people's experience and researchers and friends and supporters and patient advocates and everything on the spectrum. So I'm just so grateful for everyone's participation, and a shameless plug for ALD Connect. If you're a patient, if you're a family member or a caregiver of a patient, if you have friends that have ALD or are newly tested positive through newborn screening, please, we urge people to consider joining our patient portal, collectivizing our voice so that it can be heard, so that we can complete our natural history studies, so that we can make ourselves available for treatment and study and all the good things that can possibly come from that. Also, ALD Connect has many work groups. If you have talent or time or any interest in helping our efforts and really accelerating our efforts, just get in touch get in touch with us through the website. There are low commitment things, there are big commitment things, and really come talk to us. And if you're interested in leading fundraising efforts, if you're interested in doing bookkeeping, if you're interested in stuffing envelopes, reaching out to people on the internet, helping coordinate webinars, anything, I guarantee every single person in this room has already made a difference here today, but that you can make a difference to us going forward. So thank you again, and thank you to all the speakers and Kaylee for really drilling down all the details of this meeting. It would not be possible without you. So thank you. So feel free to continue the conversation, and we're going to go to the next room, and then I'm sure it'll ooze out into the rest of the hotel. And great, yeah, but thanks so much, and watch our calendar for next year's meeting dates.